Smita, we can start.
Okay, sir. Good morning, everyone. My name is Dr. Smita, and today's topic is Post-Intensive Care Syndrome, PICS and PICS Family, PICS-F. My moderator is Dr. Srinivas Samvedam, sir. 1 minute, sir.
Go to the next slide. You are not able. You are able to see. So you share the screen now and
Yes.
click
Yes.
next. Yeah. Okay.
Yes. Okay, sir.
Yeah.
In 2010, the Society of Critical Care Medicine convened an international multi-staker group that created the term Post-Intensive Care Syndrome. PICS was created with multiple objectives, which include to raise the awareness among the clinician, patient, families, and general public to increase screening for the specific impairments which occur after the critical illness and to facilitate the further research into specific comorbidities. Definition of PICS is PICS was defined as a new or worsening function in one or more of the following domain after the critical illness, which are the cognitive function, psychiatric function, and physical function. This definition applies to adult patients who are discharged from the intensive care unit and reside in long-term acute care rehab center in skilled nursing facilities or at the home. But patients who have the traumatic brain injury and stroke patients are excluded. It is important to note that the PICS is not a medical diagnosis, but it is a concept for improving the education and awareness for post-ICU impairments. PICS-F, the term post-intensive care syndrome family, has been coined to encompass the acute and chronic physiological morbidities among the critical care patient for caregivers and family members. It is considered the caregiver and family response to stress of the critical illness in a loved one. It includes the symptoms that is experienced by the caregiver and the family members during critical illness, as well as those that occur following the death or discharge of a loved one from the ICU. Components of PICS are the physical impairment, cognitive impairment, mental impairment, and PICS family is the anxiety, depression, post-traumatic stress disorder, and grief in the family members. Subtypes of PICS are the subtypes of physical, cognitive, and mental health outcome as it is derived from the LTOS study. It is conducted in 698 ARDS survivors who are evaluated at 6 month and 12 month for follow-up. 4 subtypes are mildly impaired physical and mental health status, 22%, moderately impaired physical and mental health status, 39% of patients, severely impaired physical and moderately impaired mental health status, 15% of the patients, and severely impaired physical and mental health status in 24% of the patients. Pathogenesis of PICS are multifactorial and complex. Possible mechanisms are ischemic changes, neuro and systemic inflammation, disruption of blood-brain barrier and white matter integrity, and disuse muscle atrophy. PICS pathophysiology. Triggering factor are 3: patient-related factor, disease-related factors, and ICU factors. In patient-related factors are the age, dementia, pre-ICU functional status, psychiatric history. Disease-related factors include admitting diagnosis, anemia, endocrinopathies, hypoxemia, infection, inflammation, etc. ICU-related factors are the prolonged immobility, invasive procedures, light, noise, and the sedation. All these triggering factors precipitate the PICS. Risk factor for the PICS are broadly categorized into pre-existing factor, intensive care unit specific factor, and individual risk factors. In pre-existing risk factors, neuromuscular disorder, cognitive impairment, psychiatric illness, comorbid conditions, functional decline, frailty, socioeconomic disadvantage, older age. In intensive care, specific factors include mechanical ventilation, acute delirium, sepsis, shock, hypoxemia, ARDS, unintentional routine or home medication disruption, glucose dysregulation, sedative medications, and individual related risk factors. Risk factors according to domain specific risk factors are the cognitive dysfunction. Major risk factors are delirium, prior cognitive dysfunction, sepsis, ARDS, sedative medication, hypoxemia, and glucose dysregulation, mainly hypoglycemia. Other risk factors in cognitive dysfunction are the acute brain dysfunction, example, alcoholism. The other are hypoxemia, hypotension, respiratory failure, congestive heart failure, sepsis, trauma, cardiac surgery, cardiac arrest, obstructive sleep apnea, acute in-hospital stress or inflammation, blood transfusion, sedatives, delirium, and use of renal replacement therapy. Psychiatric dysfunctions, major risk factors are the pre-existing psychiatric illness, sepsis, ARDS, respiratory failure, trauma, hypoglycemia, hypoxemia, early symptom of the mental health impairment after critical illness, recollection of frightening experience in ICU, and impaired physical functions. Other risk factors for psychiatric dysfunction include female sex, tall stature in males aged less than 50 years, lower education level, pre-existing disability, unemployment, pre-morbid alcohol abuse, ICU sedatives, analgesic use, agitation or physical restraints, prolonged illness, and unemployment. Physical dysfunction, major risk factors are the pre-existing functional disability, frailty, pre-existing cognitive impairment, ICU-acquired weakness, prolonged illness, older age group. Others include prolonged mechanical ventilation more than 7 days, prolonged immobility or bed rest, sepsis, MODS, ARDS, glucose dysregulation, hyperoxia, malnutrition, sensory disorder, use of vasoactive agents and steroid. Use of glucocorticoid use may increase the risk of ICU-acquired weakness, but it reduces the risk of the PTSD, post-traumatic stress disorder. PICS family-related risk factors include patient-related risk factor are the death of the patient or increased severity of the illness. Caregiver relative is the young age of patient, child of adult patient, financial instability, low education level, low socioeconomic support. Environmental related is poor communication with staff and less family involvement in counseling sessions. Complicating factors are the caregiver burden, job loss of caregivers, and financial toxicity. Risk factors are categorized into non-modifiable, potentially modifiable, and modifiable. Non-modifiable risk factors are age, frailty, female sex, cognitive impairment, mental health disorder, ARDS, and sepsis. Potentially modifiable risk factors include mechanical ventilation duration, ICU length of stay, shock, hypoxia, multiple organ failure. And modifiable risk factors include sedation use, delirium, immobility, sleep disturbances, hyperglycemia, negative memories of ICU. This is conceptual framework of PICS, like increasing elderly population, increasing number of sepsis patient, advanced ICU technologies, prolonged critically ICU patient, post PICS survivor, and PICS family, and 3 domains: physical impairment, cognitive impairment, and mental impairment. High risk patient for the PICS. In cognitive category, before critical illness, risk factors are the pre-existing dysfunction, cognitive dysfunction, and during illness is the incidence and duration of delirium, duration of sedation use, sepsis, shock, hypoxia, ARDS, and life support. In mental health category, before critical illness, if patient have high risk group, is pre-existing mental health like anxiety, depression, and history of post-traumatic stress disorder. And during illness is memories of frightening experiences in the ICU. And after illness is the early symptom of anxiety, depressions, and PTSD. In physical category, before illness, high risk group is pre-existing functional disability, frailty, pre-existing cognitive impairment. Socioeconomic factors exacerbating and exacerbated by the PICS are individual related are the non-white race, female sex, increasing age, low income, low educational level, lack of health insurances. Family related are the job loss, social isolation, lack of social support. Community related is increase distance from the clinic, limited transportation. Health related is decreased PICS clinic availability, decreased social support resources, post-discharge transitional care performance. And policy related are the decreased access to health insurance, decreased PICS clinic service, and decreased social welfare supports. Clinical features of the PICS are include a constellation of cognitive, psychiatric, and physical sign and symptom, and hallmark feature is they are newly recognized or worsening after the critical illness. Common symptoms include poor concentration, fatigue, anxiety, depressed mood, symptoms of post-traumatic stress disorder, generalized weakness, and poor mobility. Symptoms by examinations are formal testing, example, cognitive and psychiatric questionnaires, appropriate consultation like occupational, physical therapist, neuropsychologist, and psychiatric consultations. A complex relationship exists between the three individual domains of the PICS, and with impairment in one domain frequently affect the other domain. Mental health related are the depression, anxiety, PTSD, self-harm, and the suicide. Cognitive impairments include the memory loss, dementia, impaired executive function, and physical impairments include the overt disability, dyspnea, weakness, impaired mobility, malnutrition, sleep disturbances. Financial toxicity include the medical bills, job loss, loss of home, reduction or loss of income, and loss of savings. Family impact is caregiver burden, financial loss, change in family structure, grief, and mental health issues. Cognitive impairment after illness incidence is 25 to 88% of survivors, and it is best illustrated by brain ICU study, which is a prospective study which include 821 patients examined over the long-term cognitive effect of critical illness in patients admitted in medical ICU and surgical ICU with shock or respiratory failure and who required the mechanical ventilation. Points are the baseline 6% had the cognitive impairment. At 3 months post-discharge, 40% of the patient had deficit that were similar to patient with moderate traumatic brain injury. 26% of the survivors had deficit that were similar to the mild dementia. At 12 months post-discharge, the deficit persists in the most patients. The severity of the impairment varies from the subtle difficulties in accompanying complex executive tasks to profound inability to conduct activities of daily living. Areas of cognition that are commonly affected include attention or concentration, memory, mental processing speed, and executive functions. Memory and executive functions are domains that frequently prohibit the individual from engaging in purposeful and goal-directed behaviors, which are necessary for daily functioning and complex cognition. For example, this functioner critically effectively carry out discharge plan, further impairing recovery. Example, medication adherence, dietary restrictions, scheduling, and maintaining the appointments. Psychiatric impairment incidence range from 1 to 62% depending on the type of the disorder. And from several observational cohort of the critical illness survivors reported depressive episode rates symptoms are 28 to 37%, and post-traumatic stress disorder incidence are 10 to 22%. Mood disorders most commonly encountered in PICS include the anxiety, depression, and post-traumatic stress disorder. Anxiety includes excessive worry, irritability, restless, and fatigue. Depression is fatigue, loss of interest, poor appetite, sense of hopelessness, and insomnia. And PTSD is affective and behavioral response to stimuli that provoke the flashbacks, hyperarousal, severe anxiety, sexual dysfunction, intrusive recollection, and avoidance of experience that evoke the symptoms. Survivors of critical illness may have the increased risk of suicide and the self-harm. Overlapping symptoms and distinctive symptoms of the anxiety and depressions. Symptoms common to anxiety and depressions are irritability, agitation, concentration difficulties, and insomnia, fatigue. Symptom specific to anxiety is excessive worry, autonomic hyperactivity, exaggerated startle response, and muscle tension. And specific for depression is depressed or hopeless, loss of interest, weight changes, poor appetite, motor retardation, guilt or self-worthlessness, and thoughts of death. Physical impairment. Most common physical impairment is due to ICU-acquired weakness. It is most common form of physical impairment, occur in 25% or more of ICU survivors, and disability was prominent in those with or without pre-existing functional disability, and it may persist at the 12 months. Contracture and limb function. Joint contractures develop as a complication of prolonged immobility. Studies suggest patient admitting for the 14 days or more in ICU had 34% patients had a functionally significant contracture at the ICU discharge, which persisted in the majority of the patient throughout the hospitalization. Most common affected joints are the elbow and ankle, followed by hip and the knee joint. And use of steroid is found to be protective factor. Upper limb disability related to shoulder impairment is also common after the critical illness. In a study of the patients receiving ICU care for 3 or more days, 47% of the patient experience upper limb dysfunction at the 6 months. Reduced lung functions can occur due to mechanical ventilation-induced lung inflammation or respiratory muscle weakness, including undiagnosed diaphragmatic paralysis and the ARDS. Malnutrition, weight loss is common during the critical illness, especially in the patient receiving the mechanical ventilation. Poor sleep is common after critical illness, and review of 22 studies reported that roughly 50 to 66% of critical ill patients experience sleep disturbance at the 1 month after hospital discharge that improve over a time. Risk factor and consequences. Patient outcome related. If pulmonary is caused, then impairment in spirometry, lung volume, and diffusion capacities. Selected risk factors are the diffusion capacity and which depend on the duration of mechanical ventilation. And generally mild impairment with improvement during the first year, but can persist 5 years or the more. Neuromuscular or ICU acquired weakness include critical illness, polyneuropathy, and myopathy, and disuse atrophy. And risk factors are the hyperglycemia, SIRS, sepsis, multi-organ dysfunction, and for disuse atrophy, it is immobility or bed rest. Polyneuropathy may recover more slowly than the myopathy and can extend up to 5 years. Physical functions, impairment in daily activities, and 6-minute walk test. And the risk factors are the systemic steroid use, ICU acquired weakness, slow resolution of lung injury, age, pre-existing age adjusted disability life, and the impairment. And some improvement in the ADL within months, but impairment may be seen in the ADL at a 1 year or in ILDL at the 2 years. Long-lasting impairment in the 6-minute walk distance versus population norms. Psychiatric related are the depressions, PTSD, and anxiety. In depression, risk factors are the traumatic or delusional memories of the ICU, sedations, psychiatric symptoms at the discharge, and impairment of the physical functions. And it may decrease over the first year after the discharge from the ICU. And PTSD is the sedation. Risk factors are the sedation, agitation, physical restraints, trauma, delusional memories, and little improvement in the first year. Anxiety is the unemployment, duration of the mechanical ventilation. And overall risk factors are the female gender, young age, less education, pre-ICU psychiatric symptoms, and the personality. And anxiety may persist over the 1 year. Cognitive dysfunction risk factors are the impairment in the memory, attention, executive function, processing, and the speed, visuospatial ability. And risk factors are the lower pre-ICU intelligence, ICU delirium, sedation, hypoxia, glucose dysregulation, and significant improvement during the first year, and with the residual deficit up to the 6 years. Risk factors and consequences is the family outcome. Psychiatric is the depression. Risk factor, overall risk factors are the female gender, age, less education, pre-ICU psychiatric symptoms, personality, and restricted visiting. And depression and anxiety decrease over the time, but are the higher than a population norm at the 6 months. PTSD is the dissatisfaction with communication. ICU physician perceive as an uncaring, passive preference for decision making, mismatch between involvement in decision making and the preferences. Anxiety, risk factor or severity of illness is not associated with development of the symptoms, and complicated grief is worsen when the family does not have a knowledge of patient's wishes. And PTSD and grief can persist 4 years or more after the death or discharge and may not decrease over the time. Diagnostic evaluation follows the SSCM consensus statement recommendation regarding the detection of the PICS. Timing of evaluation. PICS can be identified in the immediate period of the following a critical illness. However, symptoms are long-lasting, 6 to 12 months or longer, and the condition is unrecognized. Increased healthcare utilization is very common in the first 90 days after the discharge, which is an opportunity for the clinician to evaluate the patient with the diagnosis in the mind. Who to evaluate? Evaluate every survivor of the critical illness for the cognitive, psychiatric, and the physical sign and symptoms of PICS. And and those considered at the high risk of the PICS should be prioritized for the evaluation as mentioned in the high risk category. When to evaluate? Perform early and serial assessment. This begin during the ICU admission and continue as a part of ICU to floor handoff through the pre and post discharge assessment. That is within 2 to 4 weeks of hospital discharge and continued throughout the recovery. Beginning evaluation in ICU is particularly important for those with suspected ICU acquired weakness. Early assessment identifies those with the weakness who might begin therapy early in the course, that is during the ICU admission, and subsequently, patients should be reassessed in the rehab centers at home to determine the functional disabilities that affect activities of the daily living. Example, bathing and dressing and eating, swallowing function, as well as disabilities that require the medical and the social supports. Initial clinical evaluation. Are the cognitive deficient? Clinical assessment, if feasible. The rationale for this approach is based on benefit of cognitive rehabilitation in those with the traumatic brain injury and stroke and the potential to improve the executive dysfunction in the survivors. Every patient should be asked about the memory deficit, concentration, ability to perform executive tasks. Physical weakness assessment. Involve preliminary history and examination of physical strength, mobility, adjusted daily lives joint contracture, and neurological cardiopulmonary system examination. Inquire about the dyspnea that may be limiting their exercise tolerance, nutritional status, and ask about the sleep habits, sleep quality. Subsequent testing are the clinical finding of suspected dysfunction are typically by the formal testing. Example, cognitive and psychiatric rating tools. Appropriate consultations are required. Cognitive rating tools are the consultation with neuropsychologist, Monterial cognitive assessment or Monterial cognitive assessment to be used to screen the cognitive impairment, and mini mental state examination, mini cog score, and trial making test are also useful. SSCM recommend the MOCA score for evaluation of the patient with suspected cognitive dysfunction following a critical illness, and preference is based upon the observation that MOCA score, which incorporate an assessment of executive functional abilities, is more sensitive for the mild impairment. MOCA score more than 26 is normal cognitive functions, less than 26 indicate mild cognitive impairment, and less than 18 is moderate to severe cognitive impairment with dementia. Other scores are the CADS activity of daily living score and Barthel index. Barthel index is a score which is based, this is ordinal scale used to measure the activities of daily life, which include the patient's day-to-day activities like the feeding, bathing, grooming, dressing, bowel bladder habits, toilets, and transfer to bed and back to bed, and mobility and stair. More than 100 score in Barthel is normal. Psychiatric rating tools approach in general similar to the other patient with suspected psychological dysfunction. When anxiety, depression, and PTSD are suspected, use anxiety, depression, and PTSD screening questionnaires. Formal consultation with psychiatrist is also appropriate in selected patient and those who screen positive. These are few questionnaires related means to rule out the depression and to measure the probability of major depressive disorder. And this is depression questionnaires. By this scores, we can score depression into mild, moderate, severe, and very severe category. And this one is for the PTSD DSM-5 classification, by which we can divide into PTSD into moderate or extreme categories. No optimal questionnaires exist based upon the clinical experience and the support by the SSCM. Preferred mental screening scales are the HADS score, Hospital Anxiety Depressive Scale, to assess for the symptoms of depression and anxiety. Alternative scales are the Beck Depression Inventory or Beck Anxiety Inventory scores. Impact of Event Scale revised, and the 6-item Impact of Event Scale is to evaluate for the PTSD, since they are reliable screening tool for PTSD symptoms and have been validated in the patient with ARDS also. Alternatively, PTSD questionnaires are maybe useful. Physical functional testing in suspected ICU-acquired weakness patient, 6-minute walk test or European quality of life 5-dimension scores to assess the physical function is supported by the SSCM. Rarely neuropsychological testing or muscle biopsy is required. Consultation with occupational or physical therapy is the key to evaluation. Suspected lung dysfunction patient, for all mobile patient reporting symptom, we have to perform exercise tolerance with the 6-minute walk test. Full cardiopulmonary exercise testing is not required in all patients. If previous underlying lung dysfunction is there, then we have to perform pulmonary function tests like spirometry, lung volumes, diffusion capacity, mostly on outpatient basis. Additional tests for the detection of respiratory weakness include the diaphragmatic testing. Suspected malnutrition patient evaluated by the nutrition expert to assess the level of nutrition for the future goal setting. And nutritional needs vary over the course of the recovery, such as multiple assessments are required. Poor sleep quality. Rarely sleep study is required unless the obstructive sleep apnea or other sleep disturbances in the suspected in the clinical evaluation. Lab testing are not routinely required. Only basic routine tests are important, which include the complete blood count, differential count, iron, vitamin B12, thyroid, liver function test, and chest radiography. This test is aimed at detecting nutritional deficiencies and organic pathologies that need to be excluded before the diagnosis of PICS. Evaluation are the for cognitive functions. For cognitive functions, which are include the MOCA. MOCA is Montreal Assessment Score, Cognitive Assessment Score, MMSE, and Barthel Index. And physical is the respiratory spirometry, 6-minute walk test, and MMRC, Modified Medical Research Council test. And for physical, general is review in ICU course, assess symptoms, evaluate at the new condition, medical reconciliation, or maintenance screening. ICU acquired weakness include the BBS is the Berg balance scale, 5 times sit and stand test, and European quality of life 5-dimension. MMT is manual muscle testing and hand grip dynamometry. And physiological include the hearts is hospital anxiety depression score and impact of event scale revise and evaluation of financial instability, evaluation for housing instability. Differential diagnosis are pre-existing illness, like pre-existing illness, presence and severity of the prior cognitive dysfunctions and mental physical impairment need to be evaluated to identify unchanged as well as new or worsening symptoms after the illness. Unchanged symptoms do not support the diagnosis of the PICS. Examples of pre-existing illness include the prior cognitive deficit from developmental defect, dementia, traumatic brain injury, other comorbidities like anxiety, panic disorder, depression, schizophrenia, substance abuse, physical alignment include the failure to thrive, neuromuscular disorders like multiple sclerosis and amyotrophic lateral sclerosis. We engage caregivers or family members since identifying the present and the nature of pre-existing disease can be challenged in the ICU survivors who may not have the cognitive capacity to compare their current status with the symptom prior to their admission or whom a prior existing illness is not known. Organic causes of the symptoms that mimics the PICS are the condition which include the stroke, hypothyroidism, hyperthyroidism, B12 deficiencies, anemia, cancer, obstructive sleep apnea, occasionally mimic the cognitive and the psychological or neuromuscular weakness which manifested at the PICS. So we have to exclude all these things. Testing for the organic pathology should be directed by the clinical history examination or prompted in those who respond atypically to the rehabilitation or may include the CT or MRI of the brain and sleep study also. Muscle weakness or the disorder other than ICU acquired weakness is also a DD for the PICS. Post-hospital syndrome, PICS appear to be distinct from the hospitalization-associated disability, also known as a post-hospital syndrome. It is particularly seen in the older patient with non-critical illness and can be associated with number of functional disabilities, which are often transient, day-to weakness. In contrast, the manifestation of PICS, which are the wide-ranging and are typically enduring rather than transient changes in the post-hospital syndromes. General approach, prevention and management. SSCM recommendation are ICU admission, assess pre-ICU functional abilities, document in the history and the physical examination. ICU to floor handoff, report pre-ICU functional abilities assessment, current functional abilities achieved. Hospital discharge, conduct pre-hospital functional assessment, functional reconciliation linked to pre-ICU abilities to guide post-acute care referral. Post-discharge, screen at the risk patient using recommended tools and conduct initial post-discharge screening within 2 to 4 weeks of the hospital discharge. Prevention. Prevention of PICS are strategies to reduce occurrence of PICS are reduction of the risk factor of PICS, early mobility programs, post-discharge follow-up programs, early psychological intervention, ICU diaries, healing environment of the care, ABCDEFGH bundle, and nutrition, protein intake to promote the muscle synthesis and cover the catabolic deficit. Additional factors which helps to decrease the PICS are avoid hypoxia, avoid hypoglycemia, ICU diaries, which ICU daily diaries maintenance, which decrease the symptom of PTSD in 2 to 4 weeks, PICS clinic, nutritional support, good sleep. SOS anxiolytic should be prescribed. Plan for ICU navigators, either nursing staff or the social worker, with whoever is requirement of rehab center or long-term center. That ICU navigator or nursing staff can decide कि patient may require the rehab center or long-term acute care center, wards or home. Also monitor to bring back the patient to the PICS clinic and look after the barriers to follow up and the caregivers. ABCDEFGH bundle for the prevention of the PICS are the A is for airway management, B breathing trial, C is coordination of care and communication, D is for delirium assessment, E is early mobility, F family and follow-up referrals, G is good communication, H is handover material. Rehab programs are the high-risk group rehabilitation programs include the physical therapy, respiratory muscle training, swallowing exercises, occupational therapy, cognitive rehabilitation and mental care. Reintegration into the society. Management of PICS are cognitive impairment management is cognitive retraining, compensatory strategies, exercise therapy, occupational therapy. For physical and respiratory include the oxygen titration, breathing retraining, pulmonary rehabilitation. Addressing reversible cause of the PICS and manage symptoms and the new medical condition and subspecialty referral. And for mobility aids, environmental adjustments, graded exercise programs, and physical therapies. For psychological domain, management is support groups, psychotherapy, psychiatric referral, and social work referral. Transition of care is in PICS clinic, we have to see transition of care is ICU to floor, discharge navigator screens and arrange the PICS clinic visit, then home. In 2 to 4 weeks, either patient is discharged to home or subacute care to home. And then post-ICU clinics are the PICS clinic for the evaluation and management of PICS by the team. PICS clinic follow-up. PICS clinic include the physician who examine and prescription introduction, nurse cognitive for cognitive mental assessment, consultation, outpatient adjustment, physiotherapist for the assessment and the rehabilitation, dietitian for the nutritional assessment and guidance, pharmacist for the medicine assessment and prevention in preventive intervention, and psychologist for the mental assessment and the psychotherapy. Barriers of the PICS clinic are the patient-related barriers are increasing age, increased severity of the illness, dependence, frailty. And financial-related barriers are housing instability, financial losses, lack of health income, cost of transportation. Environmental-related are the increased distance to the clinic, discharge to the long-term acute centers, and lack of the caregiver. Due to this, follow-up is not possible for the patients. So this PICS clinic telemedicine scheme is there in which same physician, pharmacist, psychotherapist, occupational therapist, speech therapist, nurse, dietitian, and psychologist all available in telemedicine so that they can evaluate and do needful things. These are the self-report version for the patient-related questionnaires. If patient is able to tell his feelings, they can they can use these questionnaires, and according to this, we can decide the patient symptoms, cognitive related, functional scale, behavior scale, and scores. And key points are the PICS impact up to 80% of the patient who survive in the ICU, resulting in physical, cognitive, psychological impairment. Intensivists should attempt to minimize the common modifiable risk factor for the PICS, which include sedatives, immobility, delirium, sleep disturbance, hyperglycemia, hypoglycemia. Maintain ICU diaries as patient as early as possible when patient is admitted in ICU, which is either written by patient with patient help by the staff or by the family members. And social and financial impact of the PICS can be substantial. Up to 50% of the patients who survive in the ICU rely on the long-term family care support, and up to 40% of previously employed patients who survive in ICU are unable to return to work 1 year after the critical illness. Survivors of critical illness should be outpatient follow-up within 4 weeks of the hospital discharge, with structural assessment for the physical, cognitive, psychological domains, and should refer to the PICS clinic should be made if available, and plan for ICU navigator who will arrange everything. And this is briefly all things explained in one chart. Thank you, sir.
Thank you, Smita. I think it was a very good review of a topic which has received a lot of attention in the last 4 or 5 years, post-intensive care syndrome. Mainly because of the COVID and the post-COVID syndromes, people started looking at medical aspects of post-intensive care syndrome, but it is much more than the acute medical aspects of intensive care with post-intensive care syndrome actually means. We have been actually measuring this for quite some time, 2007 onwards, since our first patients who got discharged came back for follow-ups to us. We have been following these patients. Some of them have nutritional deficiencies, some of them have peripheral nerve weaknesses because of restraints and because of neuromuscular blockade, they have nerve palsies. Those are the physical aspects. The pre-RDS patients tend to have right heart failures, a lot of other issues, but most importantly, these patients who have gone through a lot of organ dysfunctions in critical phase of their illness tend to have neuropsychiatric manifestations. Several years after they have been discharged from the intensive care unit, like getting up in the night with nightmares of nurses and doctors to you. Some of them have CPR done. Some of them can recollect a few vague feelings and vague visions which they have seen during the CPR. There are multiple such neurocognitive dysfunctions which happen in these patients, which is probably a tip of the iceberg. We don't look at it too much in our patients. We maybe 6 months follow up or 1 year is maximum unless they are part of some clinical trial. But post-intensive care syndrome is a multidisciplinary problem. It's a multidisciplinary syndrome and therefore requires a comprehensive approach. It is not only the patients who suffer from this kind of problems, but it is from the family also, which is PICS-F. The family also suffers a lot from the separation they have faced from the patient during this tenure in the intensive care unit, and subsequently taking care of these patients at home would probably be adding to the burden on the family and their psychiatric behavior as well. Needless to say, high-end intensive care is an expensive business in India. The financial implications have also of intensive care, and especially prolonged intensive care, have had some impact on the social relationships in the past, and it's a fact we can't just wish away. So I think post-intensive care syndrome is a real entity, and more data needs to be gathered about it before we understand how this can be better addressed during intensive care and at the time of discharge. Ghanshyam, you want to say something?
Thank you, Smita. It was indeed a very extensive topic. A few points from my side. I think as intensive care specialists, many a time we ignore this aspect of ICU, which, as Srinivas has said, has gained a lot of importance in the recent times. our focus is always on resuscitation and survival. But what happens to these patients after they get discharged from the ICU? Most of us either don't have follow-up or probably just hand over the care to the other primary physicians and hence don't have an idea about uh, their actual quality of life. I think, first and foremost, we need to have regular post-discharge clinics because many of these symptoms can be diagnosed and identified when the patient comes to you on a regular basis. If you look at the role of allied specialties like the role of a nutritionist, the role of a physiotherapist, many a time that is often ignored. But again, if you go to the presentation, as Vita has highlighted, one of the key aspects is rehabilitation and nutritional interventions. Many a times these things are aggravated, especially during the transition phase when patients are shifted out of the ICU to the ward, where many a times your nutritional support is compromised because till then the patient in the ICU would be either on Riles tube or some sort of a nutritional support intervention. But once the patient is extubated, where you have difficulties in swallowing, where the ability of the patient to take his complete meal is compromised, where the Riles tube is removed, there is a substantial amount of period where the patient's nutrition is severely compromised. Similarly, if you look at the role of physiotherapists, we generally involve physiotherapists very late into the care of the patient. And that is something that we need to seriously look at it. It is a continuous process. So if we have to look at preventing or decreasing the incidence or the severity of the PICS, then we need to involve these allied specialties at a very, very early stage of ICU admission, from where they can be involved into the transition as well as discharge care so that an individualized plan is maintained. See, not everybody is going to have the kind of infrastructure where advanced physiotherapy or rehabilitation equipment is available. So we need to individualize their post-discharge care based upon the available infrastructure, based upon the available support system they have, either in the hospitals, in the wards, or at home. The ISCCM is coming up with a post-intensive care position statement. I am happy to be a part of it. I think that's going to be published very, very soon. Hope that will be of some help to all of us. I think that's it.
So I think we look forward to that position statement. It is important guidance for us. Because patient's care doesn't end when we write the discharge summary. Patient's care does not end at all in intensive care. I believe subsequently, who actually had no coronary issues, um, had no coronary issues while they were in the hospital, were admitted for totally different problem, tend to end up having acute coronary syndromes 1 year or 2 years down the line. We don't know whether it is related to the stress of critical. So it needs to be followed. I think more data. We'll hear about this more often in the future. So thank you all for joining us today. Next week, we will start a new series on mechanical ventilation. And please do join us again next week. If you have any comments or questions on the topic we presented today, please do post it on the group from where you got this link from, and the moderator and the speaker will try to answer this question to the best of our abilities. Please do also register for the HICS symposium. We already touching 200 registrations. We hope to see more of you here. Please do register for the HICS symposium on May 10th, 11th, and 12th. Thank you very much. Have a good day and be safe. Bye bye.
Thank you.